Good morning, good afternoon, good evening, wherever you're joining us live or maybe watching this recording. It is really an honor and a privilege to kick off our February small baby course, the first time we've done this in Synapse Care, with this amazing presentation that I know that Jane Solomon and Dr. Vargas have been working on for a while. It is a new passion project that has really exploded. I mean, I think we've all been passionate about small babies, but really putting some real framework and some intention on this work. And it has been a blast working with them. And I'm so excited to share everything that they have been going on. So Dr. Vargas, as many of you maybe recognize and remember, was a presenter at our one conference last year, and he presented on the Maybe Baby, which we were just talking about was probably one of the most memorable and presentations from last year. People ask about that talk a lot. And so it's really fun to have you back in this new context and in this new role, sharing all of this. So I know you love baby brains, and I know that you and Jane and the team there have been just doing amazing things. And so as a formal introduction, he's the Associate Medical Director of the NICU at St. Joseph's Women's Hospital in Tampa, Florida. He's also the medical director of their hypothermia program, which is, how we got to know him first. But this is really exciting how he and Jane have conceptualized this. We've been able to work together on it. And I'm excited to hear just this overview, where we are, where we're headed, and just some vision that they have for the future. So with that, Dr. Vargas, I'll let you take it away.
Thank you so much, Kathy. It's an absolute pleasure and an honor to be here, to be able to present to you today, and to just be a part of this conference. I mean, the enthusiasm you bring to caring for small babies is just palpable. It's contagious. I love everybody, being here, signing on to do this. And you guys are in for just an amazing course over the next few months, focusing on the care of these small babies. What can we do to improve their survival? What can we do to improve their intact survival? So I think we'll get started with this presentation on the small baby unit, what we're developing here in St. Joe's. I'll get into that a little bit. So the title of our talk is Every Little Thing Matters to a Small Baby, and little things do matter. And it's amazing the privilege we have as neonatal providers to impact a baby's entire life. And sometimes seemingly just very small things we do at the bedside on any given day can have a lifetime of repercussions for that little person in front of you. So making very conscious decisions about how we proceed forward with small babies, again, can have a very lasting impact. Let's see. Okay. Our objectives, we're going to talk about some global and US statistics related to extremely low birth weight babies, their population, and some of their outcomes. We're going to discuss some major factors related to morbidity and mortality in this particular group of babies. And then we're going to go through 3 quality improvement strategies that we can use that hopefully you guys will be garnering from this course to take back to your units and affect outcomes on your specific populations of babies. So on a global scale, prematurity is still a huge problem. It's the leading cause of infant mortality worldwide. On the planet, there's about 15 million preterm births per year, so defined as under 37 weeks, and 1 million of those babies will die before age 5. The vast majority, so this is heavily weighted to the smaller babies. So mortality, and we'll look into some of these numbers, obviously at 35, 36 weeks is going to be a lot lower. So the real gist, or the real large chunk of mortality occurring in these infants is in the very small babies born under 27, 28 weeks and under 1,000 grams. And those that do survive oftentimes do face a lifetime of disability, whether it be chronic lung disease or learning disability, cognitive impairment, significant visual problems, hearing problems. So there's a wide range and a wide scope of disability affecting these small babies. So here in the US, we account for about 3.7 million births annually, of which about 10% are premature. So again, defined as under 37 weeks. Extremely preterm infants, however, so those under 28 weeks, under about 1,000 grams for ELBWs, they contribute disproportionately to both neonatal mortality as well as long-term morbidity. One thing I love to check on periodically, certainly once a year, go back to the March of Dimes website to see how things are looking around the country. And the March of Dimes does assign a grade, if you will. So A, B, C, D, or F, which states are doing well, which states aren't doing so well. And you'll see that across the United States, there's varying degrees of preterm birth. The only state to get an A is Oregon. That means that their rate of premature birth is much lower than the rest. But you'll see the southeast of the United States, not so good. There's a lot of states that receive an F. Usually, some of the things that will tie into increased rates of preterm birth will involve socioeconomic status as well as access to healthcare. So those states where out of proportion we might have worse access to healthcare or more poverty, obviously in those states we may see a little bit more preterm birth. Now, when looking at survival and mortality, there's a just proportion. So when you look at this graph, the dark blue line looking at surviving infants, the vast majority of babies who survive. So if we add up babies born 37 through about 40 weeks, that accounts for about 90% of babies that are surviving, versus if you look at the 32 to about 36, all up, that's only about 12% of babies who survive are in that lower gestation. Yet when you look to the right at the lighter blue, those smaller babies, those more premature babies, they disproportionately account for a high percentage of the mortality. And if you look at babies born under 32 weeks gestation, they account for 60% of the mortality we see in infancy, even though they represent a very small actual number of babies. So again, a disproportionate number of babies dying at this small gestation and small size. So just some definitions, ELBW, which will be the focus of our small baby course, really refers to babies born under 1,000 grams. So that's just by definition. If you hear the word extreme prematurity, that's generally relating to or pertaining to babies born under about 27 weeks gestation. So again, the focus of this course. But why focus on them? Well, these babies lose a ton of time in the womb, a ton of time in the uterus, during which time in a normal intrauterine milieu, those babies should be developing normally, should be developing nice alveoli, their gut, their brain. You interrupt that cycle, you lose a lot of that normal development that should occur in the womb. And that puts these babies at a very high risk of increased morbidity that's very unique to this population. So it's very much a developmental arrest that happens, and then abnormal development that happens following that premature birth. Preterm birth is still the number one cause of long-term neurological problems and cognitive impairment and cognitive delay, and there's an increased length of stay. These babies, obviously a term baby might be in your hospital for 48 hours. These premature babies obviously will sometimes stay for much longer than that, and so there's a huge strain on our hospital system, and it's obviously a huge financial burden as well for our hospitals. So which of these babies are surviving? This graph really kind of looks at various different databases for newborns across several different countries. And you'll notice on the bottom axis, we're starting at about 22 weeks, moving to about 28 weeks. So again, just kind of looking at this ELBW or extremely preterm population. And survival, if you look at the red line, for example, looking at Japanese data, their survival reported for 22-week gestational age babies is approaching 40%, where you'll see that most other countries were reporting much lower survival, many anywhere from 0 to 10%. I will tell you that at this very low gestation, a lot of what makes this number different from country to country is whether or not even active resuscitation is offered at that gestation. So in many countries where active resuscitation at 22 weeks is not offered, obviously the mortality or the survival is going to be very low. Versus in Japan, it's quite commonplace to have resuscitation offered at 22 weeks. Obviously their mortality reported is going to, their survival that they report is going to be much higher. Once you approach 27, 28 weeks, regardless of what country you're looking at from these various databases, survival starts to kind of gel together, and we start to get closer to maybe 80-90% survival by the time we hit 27 to 28 weeks. So again, really honing in on the smaller babies, not only getting them to survive, but survive without disability. And that's what this graph is looking at. So this is from 3 different databases from the United States, Sweden, and United Kingdom. Looking at survival with or without disability. So on the left, we see how many babies are surviving with mild or no disability. So at the smaller gestation, obviously fewer babies are surviving with mild or no disability. Those are the babies that are going to have a much higher risk of having long-term disabilities as assessed by a Bailey 3 with either cognitive or motor delays, moderate to severe hearing loss, or visual loss as well. Now, when you look at moderate disability, again, the higher percentage of babies with moderate disability are going to be at that 22, 23 week gestation, then and it slowly tapers down, again, with some variation country to country. And then babies with severe disability, the vast majority of them are the ones born at 22 and 23 weeks. The babies with severe disability, that really seems to taper down starting at about 24 weeks. It's much less likely. So really, again, honing in on those small babies. So which morbidities are we talking about? And oftentimes for us, it's really about, well, what are the things that will cause our babies to have significant issues once they leave a hospital, or which of these things will cause our babies to die, right? So those are the things we kind of focus on. And these are also measures that are tracked not only by our hospitals, but by insurance companies, and again, by all these various different databases. So the 5 that we really focus on are IVH, ROP, NEC, BPD, and sepsis. And again, these are what's important to kind of step back and look at when you're looking at morbidities is what we have a problem with here at my hospital may be very different than what you have a problem with at your own hospital. So I do encourage you, be familiar with the rates of the various morbidities in your own location, in your own environment, because that may dictate moving forward what you decide to put the most energy into. If your unit does a very good job at keeping your NEC rate low, then you don't need to spend too much energy on designing programs that are designed to reduce NEC. You may put your effort elsewhere. Whereas a different unit, they may have horrible NEC rates, and that may be where they want to put the most effort into. So when you look at these morbidities, and again, these are the things that we can track and that we know kill babies or cause babies to have significant morbidities long term, it's important to know where your own rates are and access that information, because that helps you come up with a plan. The reason I love this graph is because it puts some of those morbidities into a little bit more of a linear context. And what I mean by that, if we're looking at this graph, kind of moving left to right, we're looking at things that are causing mortality over time. And obviously that shifts. So when you look in the first 12 to 72 hours, we see a respiratory distress syndrome, which is the light blue, vastly responsible for most of what we see in terms of mortality in that initial couple of days. Immaturity just is listed as a common cause of death. But then you see the green, for example, infection starts to creep in a little bit later, closer to 3 to 7 days. Then it exponentially becomes more common or more common cause of death as you approach 3 weeks to a month, and then it kind of starts to taper down. Whereas the red, BPD, you're not going to see death related to BPD initially. So BPD, we start to see maybe at about a month of age, and then it peaks at about 2 to 3 months of age, but it continues to become or be a problem or a cause of mortality in our babies even after 4 months. So you see BPD progressively gets higher and higher and higher as far as a percentage of cause of death. The reason I like to look at this or think about this, and again, something to just kind of think about for your own practice in your own unit. Even though BPD does not really rear its head as a cause of mortality until about a month to 2 months of age, there are things that you do in the first week, 2 weeks, 3 weeks of life of how you manage that baby's ventilator, how you manage that baby overall, how you manage that baby's nutrition, that will impact how many babies in your unit develop BPD in the first place. So even though BPD is a cause of mortality later on, you have to do something earlier to prevent those BPD cases from happening in the first place. So again, it's important to know what kills babies at particular times, because that allows you to take care of the patient in front of you, but always knowing and always understanding that there are things that you're doing right now that may affect morbidities that can creep up later on, and again, cause major issues with either severe morbidity or mortality. So that's why visually I really kind of like to look at this picture and kind of get in my head, what are the things I'm worried about now? What is causing babies to die at the particular age of the patient in front of me? But what are the things that I need to look at on the horizon that could be looming down the line? How do these morbidities affect the brain? And again, when we talk about long-term morbidities in babies, oftentimes we think about the neurocognitive problems, things that are actually going to cause significant impairment in that and impairment in quality of life, or affecting quality of life for our patients. So there's several different ways that we know that some of these morbidities can affect the brain. And for sepsis, we know infections do cause an increase in cerebral palsy, an increased rate of cerebral palsy or risk of cerebral palsy, as well as neurodevelopmental impairment and long-term issues with lower cognitive and motor scores on the Bayley. IVH can cause dermal matrix injury, post-hemorrhagic ventricular dilatation, and we know if babies develop hydrocephalus to the point where they need a surgical intervention, that in and of itself is associated with a much higher incidence of mortality and or significant morbidity, and can cause white matter injury as well. NEC is associated with development of cystic PVL, and again, an increased risk of cerebral palsy. BPD is a well-known cause of lower IQ long-term. So again, we talk about things that impact babies for life, and how something that we're doing at 1 week of age can affect the next 72 years of a person's life. Again, so working on preventing BPD, you're actually working on preventing the downstream effects of BPD, which again include a lot of these cognitive concerns and delays. And those babies obviously have long-term medical needs with lots of utilization of medical resources, even post-discharge. And we know that suboptimal nutrition interferes with normal neurogenesis. There is tons published on how important even just measuring head circumference and attaining normal head growth is related to long-term neurodevelopmental outcomes. So we know growing these babies, growing their brains while they're in our unit affects how they perform long-term far after they've left our units. So how do we face this challenge? What do we do about this? Like, obviously, these are huge problems to tackle. They're all multifactorial. How do we tackle them? And so looking at this, at kind of facing this challenge, we can start big and then kind of go small. So on an international level, there's amazing work being done by the Newborn Brain Society, and I certainly encourage you to look them up and attend their webinars, which are just full of amazing information. On a national level, we have the March of Dimes working to promote not only awareness of prematurity, but also to tackle prematurity and bring down the rates of preterm birth. At the state level, we have the Florida Neonatal Neurologic Network out of University of Florida in Shands, and they've helped a lot of hospitals around our state develop neuroprotective strategies and neuroprotective guidelines, schooling guidelines that'll allow us to perform in an evidence-based manner and in a manner where we are helping each other out and collecting data together. And then there's unit-specific solutions. So like a small baby program, like an ELBW program, which again, we'll be talking about what we're doing here at St. Joe's and what maybe many of you are doing in your own units, and maybe the reason why you're attending this conference is, how do I take this information back to my unit to make a change? But ultimately, it all boils down to you, because this does not start unless you have that drive as an individual to not only become better at what you do, but to impact the work of those around you. And so it is very important that this comes back to you. So how do we do that? Well, one of the things you'll be looking at throughout the course is this sheet that I'm showing you here, where it's the observe, navigate, evaluate sort of cycle. And what this does is it reminds you that you as an individual, you as a bedside provider, can just look around you, look around your workspace, look around the baby's environment. Is there something there that you think needs to be addressed? Is there something there that you're not quite sure about? Is there something there that you think can be better? And then writing it down, so that making yourself accountable for coming up with an answer to that problem, looking into it. And that's how things start. You're not going to create a small baby unit by yourself, but this is how that drive starts. It starts with looking around your own environment, asking yourself, what can we be doing better? And then sometimes asking that question leads to much bigger projects. And it's always, again, important to not underestimate the value of which you can bring as an individual to the unit around you, and ultimately to improving outcomes in the patients we take care of. So we mentioned, obviously, this small baby course and development of small baby units, but how do we know that these small baby units work? Well, there are, and we're going to go into some of the publications looking at how we know these work and how we know using evidence-based projects works. But there's specialized care using evidence-based protocols. We know they improve outcomes. And again, we'll go over some of this in a little bit more detail. Implementation of best practice guidelines with additional staff education and a dedicated group can impact major morbidities. So that's more looking at an actual multidisciplinary small baby unit, for example. And again, we'll go into some examples. And then team-based implementation reduces morbidities for ELBW infants and can also improve staff satisfaction. This paper from Archives of Diseases in Childhood, again, this is from 2020. So this paper looked at 10 different Vermont Oxford NICUs. They enrolled a total of about 6,000 babies, and they focused on reducing major morbidities in babies born 23 to 27 weeks gestation. They developed morbidity-specific toolkits, and what I mean by they were implemented variably is kind of what I was talking about a little bit earlier. One unit may have a bigger problem with neck, one unit may have a bigger problem with BPD, another unit may have a bigger problem with ROP. So how they implemented their toolkits really depended on what their specific issues were at their institutions. So these toolkits again were adapted by institutions to implement it variably depending on their low-hanging fruit locally, what they had the most issue with. And then they looked at several years worth of data, and the greatest sustained impact that was noticed was in reduction of chronic lung disease, in improvement in growth, so reduction of babies who experience extrauterine growth retardation or growth failure, and in morbidity-free survival. And they had initially reported data extending from about a six-year period from 2010 to 2016, and then they again reported data through 2018. So anything, and again, this is great news if you're looking at implementing a small baby unit in your hospital, that you're not only going to see short-term improvement in outcomes, these outcomes have proven to be sustained over time. If you continue to put effort into staying, again, evidence-based, continually evaluating your own unit's morbidities and your numbers, and again, tackling what's important to your individual unit. This paper from Active Pediatrica looked at again, this is a single unit. They were looking at infants at less than 27 weeks gestation, and they randomized infants. 37 went into this group where they had a dedicated small baby group, and they had 40 infants in a control group where they were just receiving their normal routine standard care. This group of 37 was cared for using a small baby model, again, with protocols designed for ELBW babies and by a select group of caregivers. And what they noticed was in the small baby group, they had much improved rates of BPD, so survival without BPD, survival without severe IVH, and then length of stay was also much shorter in the small baby group. So in this relatively small paper from one unit, they were able to demonstrate that having a dedicated small baby unit impacted not only their morbidities, but also significantly shortened length of stay, which obviously is a huge win for the hospital and reduces our utilization of resources. This last one from JAMA was also published this year. So this again is looking at these small baby units and again, demonstrating that this is from a single hospital in California, that they were able to reduce with this small baby unit approach, with having a distinct unit with, again, specifically trained providers and specifically designed protocols for small babies, that they were able to reduce the rates of hospital-acquired infection. They significantly also reduced rates of BPD in their survivors, and they had improved growth. So again, very similar to what's reported in other hospitals that have implemented small baby units. This paper was published in JAMA just this past year, and really kind of looking at team impact. But what we were looking at is outcome models that we use to talk to parents about prognosis, where we kind of go into, say you're going in to do a prenatal consult, I'm going to look up some information to tell this, to counsel this family, their baby's going to deliver at 23 weeks. a lot of the data that we use to counsel parents as far as survival and morbidity are concerned, some of that data is fairly outdated. And a lot of that data does not account for variation in resuscitation practice. And if you recall from one of the earlier slides where we were talking about variation in practices around the globe and how that impacts obviously survival, if you're not offering resuscitation, survival is going to be close to zero, right? So if you're not accounting for that variation, are we really giving parents the right information when we're counseling them about delivering a 23-weeker in your unit? So what they did with this paper, they looked at 656 different centers from Vermont, Oxford, and also from the Neonatal Research Network. And they looked at active resuscitation. So when looking only at places that were actively offering resuscitation to babies 22 to 25 and 6 weeks gestation, and this was done over a 10-year period. So 2006 to 2016 is the data that was collected. And they were looking at the main outcome of death before discharge, but also secondary outcomes in terms of long-term neurodevelopmental impairment, as well as utilization of hospital resources. And when comparing what they looked at, again, just teasing out variation in resuscitation practice, is they were previously we had seen survival of 62% reported, but with this new look at the data, survival is actually closer to 70%, again, in all comers 22 to 25 weeks. But one of the key things, and I put it here in quotes, that kind of struck me is they report the hospital of birth contributed substantially to outcome prediction. And I ask you, should the hospital a baby is born at really affect their ability to survive or survive intact? It's not a conscious choice that the baby's making where they're born. So that is telling us we need to do a better job to eliminate that sort of thing. And again, why this program is so important, why I think a lot of the take-home messages you're going to get in the next several months are incredibly important, is because you want to make sure your hospital, your unit, is the one that's providing the best possible care for these babies to improve their outcomes, improve their survival, improve their intact survival. So just kind of keep that in mind. Again, it just doesn't seem fair that a baby born in one place would not do as well as a baby born in a different place. So I challenge all of you to bring that concept back to your own units, and again, try to make your unit the one that is succeeding at taking the best possible evidence-based care of these babies. So knowing all of these things, what did we do here at St. Joe? So now bringing it down to our local level. So we decided, there's enough data out there to suggest that the best we can do for our babies is to create an ELBW team. And some of this happened, again, going back to look at our own data, looking at our own outcomes, and then seeing where we were doing well, where we weren't doing so well. And what we noticed was a couple of things. Over the past 3 years, our extremely low birth weight survival has increased every year. It's gone up. It's almost doubled in 3 years. Along with that, then, the next thing we saw is we're getting more rates of BPD, more ROP, more NEC, but not more NEC, we actually have less NEC, more ROP, more BPD. So these are outcomes and potentially more IVH. So we expect to see that because we're having more survivors at this very low birth weight, extremely low birth weight, extremely preterm babies. So as we have more of them survive, then of course we expect to see more of the morbidities that we tend to have in those babies. So now the next step is, now we're making them survive better. Now, how do we eliminate or mitigate or reduce the morbidities associated? So this is our next logical step. We're keeping them alive. Now, how can we take care of them so that they're surviving with less morbidity? So we created a dedicated multidisciplinary team. So it involves nursing, respiratory therapy, social work, the physicians, the nurse practitioners. Again, so this is a multidisciplinary team. And our therapists, of course, are occupational therapy and physical therapy and speech therapy. We want to be experts in state-of-the-art evidence-based care for babies born under 1,000 grams. So that involves a lot of education of all the moving pieces and all the parts of this puzzle. And we decided we would focus on the first 21 days of life. And again, just kind of bring your attention back to that prior graph where we were looking at what causes mortality at different stages. Again, we figure if we focus in on those first 21 days, we're still going to have long-lasting impact and reduce mortality at 3 months and 6 months of age, because we should have less BPD, right? And and BPD is killing babies later. But if we do things strategically and evidence-based and methodically in those first 21 days of life, we should also reduce mortality related to later morbidities. The other thing was we decided we needed to kind of have a fresh look at how we view care of the small baby. And oftentimes we kind of get locked in on, well, this is nutrition, that doesn't affect the brain, or this is lung, that doesn't affect, the gut, or this is gut, it shouldn't affect, the heart. When really our babies are like Rubik's cubes, except they're not a solved Rubik's cube. When we get them at 23 weeks, it's a mess. It's there's like red, blue, yellow, there's green everywhere, so it's a mess. What we have to do is create or solve the puzzle, right? Get every piece to line up. And sometimes if like, say, just to use this analogy, the red is my nutritional plan and the blue is my ventilatory plan. If I make changes to blue, that's going to move red. If I make changes to red, it's going to move yellow. So everything we do to this baby is interconnected, which is why we really have to think of the baby holistically, not just as individual systems, because any system can affect another. And what we do to promote better nutrition is going to reduce my rates of BPD. It's going to help my lungs. If I have better BPD rates, that's going to help my brain, because I'm going to have less likelihood of developing neurocognitive delay or lower IQ as that baby gets older. So again, think of that baby as a Rubik's cube, and we're really trying to line everything up, and everything we do in one system may affect another system. So kind of coming up with that really helped our staff understand just how important every aspect of care for these babies is and the implications that there are. We designed this driver diagram, and if you look in the middle, we figured we divided this into key drivers. So what are the things? What are the headlines? The different I guess components of our ELBW program. So we broke it up into thermoregulation and skincare, respiratory management, nutrition, family care, infection control, and then developmental. So we broke it up into those, and then we assigned different leaders to each. We figured we had to have some aims, and we had to have some manageable or some measures that we could look at continuously as we deploy this process and this team. So our primary aim was to decrease morbidity and mortality among infants less than 1,000 grams or less than 28 weeks. And again, I think when you think of a small baby unit or a ELBW unit, and again, for most of you, the reason you may be here, that's what you want to do. We want to decrease morbidity, decrease mortality, and we want to make sure people are complying with the bundles that the group develops, that the small baby program develops. What are things that we can measure? So again, this may be different for your unit. What is important to your unit may not be what's important to my unit, or the things that we need to work on. But the measures that we implemented, we wanted to look at time to full feeds, minimizing that, exclusive human milk diet, no hypothermia on admission, no infection beyond 3 days, so no late onset sepsis. We wanted to have less than 50% of our infants on invasive ventilation by day of life 30. We wanted to make sure we were using the Tortal in 100% of cases. And Tortal for us, and if you're not familiar with it, is just an immobilizer for the baby's head that keeps the baby's head midline. We keep it on for 7 days of age, and we have seen a significant improvement in our IVH. It's part of our IVH bundle. It's not the only thing we use to prevent IVH, but it's part of the bundle. So again, putting that baby in the Tortal right after it's born, keeping it on for 7 days, and keeping the head midline. And then we want to have no neck cases. So these are all measurable things that we can look at to see if our program is succeeding. And again, I encourage you to look at your own unit and see what the specific outcome measures that you think might be related to the problems with morbidities that you have locally, because that's what you should focus on, is what are the things that your unit is struggling with. We organized this in a multidisciplinary fashion. So we have several physicians involved. We have several team members from nursing and nursing administration, nursing leadership, respiratory therapy leadership, nutritionists, and again, our therapists. And we gave everybody, we assigned every band or every driver a leader, and that person is then the person who's accountable for collecting all the evidence they can in their own within their band, and coming up with plans that are representative of their band. So again, in your unit, as you deploy, I'm just showing you how we did ours, but as you deploy, it is important to have people lead different parts of the unit. There's not one person who can tackle this. This is an enormous undertaking. And again, the other key part of this is you need people from all the different disciplines within your hospital. That's how you get better development of these projects, but also you get much better buy-in if everybody understands and is a part of the development of your program. We do have checklists that are at the bedside. So these are specifically designed for the nurses at the bedside. And the checklists include components of each individual band or each individual driver. So these are things that they can actually look at on the bedside, during their shift to make sure that we are accomplishing or that we're doing everything that the ELBW bundle requires us to do. So again, it's such a big task and it's such a big project. We don't expect everybody to know everything from our ELBW program off the top of their head. So it is important to have something at the bedside to just function as a reminder. I need to be doing this. I need to be doing that. So again, having a checklist of what things need to be accomplished at different time intervals is very important, I think, for the success of your program. For our deployment of our ELBW program, we did set ourselves with a timeline. Again, just because of the size of the project and scope of the project, we knew it would be very difficult to deploy all the bands or all the drivers at the same time. So we figured it would make much more sense to set goals, to set a timeline in which we knew we would have one bundle ready this month, then the next bundle we're working on for the next couple of months, and so on and so forth. And the order in which we aligned the bundles, again, was a unit specific. There's unit specific reasoning for why we wanted one bundle ahead of another. So again, if your unit is struggling with something significantly, that may be the bundle you want to work on first and get deployed first, and you can leave other stuff that you think you're already doing well for later. Or there may be a bundle in there that you think, oh, we're already doing a lot of this stuff, so this will be easy to deploy because we're already doing a lot of these things. So maybe we'll do that first. And then move on to the next one. So again, how you deploy your program back in your own unit may again depend on the resources you have, the particular problems that you're facing, and maybe projects that you already have ongoing may impact how you develop your timeline. And then we just invited everybody. We invited our nurses, our respiratory therapists. So again, people from multiple disciplines to email us and tell us if they wanted to be a part of the ELBW team. So again, I think in order to get the best results, in order to get the most amount of buy-in, you need people that are actually very interested in this, that are passionate about this, that want to help, that want to develop, and then engage them. So for us, it was very important to have people actually want to join our team, want to be a part of this process. So we did issue that invitation. We are also offering our folks preparation for the ELBW certification provided by the NCC, and we hope to have probably many on this call, on this webinar today from our team are participating in this amazing course, again, to get as much education as we can to do the best possible job that we can. So with that, I just want to thank you for your time. Again, congratulate you for being here. Again, the fact that you're here says a lot about your passion for caring for these small babies. And I really hope that you get as much as you can from this course to bring back to your unit so that you can become the change for your own unit.
Thank you so much, Alfonso. That was fantastic. There were lots of really great comments and a couple questions. And I think you started to touch on it at the end, but maybe, I don't know if Jane is actually in the same space or nearby or on another phone, but the question was, how do you create a dedicated team and not create a clique and create that isolation and then maybe how do you think about onboarding people later? And I know this is a challenge in hospitals where they have the cooling team, right? How do you then do that? Or the PIC team or the transport team? So maybe we've done it before, but do you guys have any special advice on how you guys are managing that, or others on the call can chime in?
Yeah, I'll actually let I have a couple things I might say, but I'll have Jane come in and help with that question.
Thank you. Hey, it's Jane. So I did think a lot about that because the last thing you want to do is alienate people. You want to invite everyone from your seasoned nurses to your new interns. They all bring a lot to the table. So the strategy for this was to put out an invite to the entire team with an element of accountability, which kind of changes and weeds out the people that actually are going to join the team. So with this, it was, yes, you're all invited to the elbow team, but here's the criteria that you will need to meet. Here are the accountability measures that we're putting in place. And to finish the course is part of it. So we will have weekly check-ins, and probably I'll be interested to see, and I'll be happy to report, we have 100 team members that have signed up and have are starting the course. So let's see how it goes toward the end. And if I have 50% of that, that would be perfect. So I think that's the best answer, is to give it out to everyone and then let things fall out, but definitely have timelines and measures for accountability. And that's probably one of the reasons that we have the one methodology page.
Yeah.
In our unit, that's going to be a requirement for someone, each bedside nurse or a couple of people at a time, to submit weekly, and we'll review that. And the other reason for that is we want to hear from the bedside nurses. Hey, if there's 10 nurses that all identify one very simple issue, we can fix that. And that's very rewarding for the team to know, hey, I looked at something, somebody heard me, and we made a change. So, and I'll give it back to Dr. Vargas.
Thank you. And actually, you mentioned the cooling team. We did exactly the same thing with the cooling team. So when we developed our cooling program 8-9 years ago, we started with a core group of nurses, but we again issued an invitation. This is what this team is going to be about. This is our mission. These are our goals. If you're interested, sign up. You'll come. We'll have a little discussion. We'll have some education, and then if after that you're still interested, once you understand what you're signing up for, then by all means you become a member of the team. And we continue to provide ongoing education for team members, and then we do allow opportunities for other team members who didn't join initially to maybe they get wind of, hey, you know what, maybe I am right for this. Maybe I didn't click with it initially, but as I've seen things deploy, I'm feeling more comfortable with this. Maybe I do want to join now. So we do give ample opportunity for people to join. On a yearly basis, we have a whole education day where we orient new people into the cooling team and allow current cooling team members to come participate, and just to get sort of a refresher, where we have a full day of presentations, hands-on experience with cooling supplies and whatnot. And that's exactly how we're approaching our small baby unit, is inviting team members, gauging their interest, providing an overview of what is required of you to be on this team, and then if after that you can commit to it, then you stay on the team. If it's not for you, then it's not for you. Right. But it is important that the people that are on the team, again, want to be there and are passionate about it, and are people that are movers and shakers. That's what we want.
Yeah, absolutely. Well, I invited Dr. Raylene Phillips to chime in on this because of there was a question from Nidhi in the chat about the difference between community centers and academic centers, and there are differences in that. And I think that what Raylene and the team at Loma Linda have done is a nice, complement, or even in some ways a contrast to what they had to do with the size that they had. So I don't know, Raylene, if you're in a place that you can talk, or if you want to weigh in on this question around cliquishness and how do you expand the program over time?
Sure, Kathy, this was a great presentation. Thank you so much, Dr. Vargas. I just wanted to, for our unit, we actually required everybody in all nurses and all physicians and all RTs to take a portion of our, we call it a tiny baby program, our tiny baby program education. And the reason we did that is because as babies graduate out of our tiny baby program in our unit, they are cared for other nurses that are not particularly focused on our tiny babies that are less than 1,000 grams at birth. So at a certain point, they graduate out. As new babies come in to take those, we only have 12 beds in our unit. And so we wanted them to have some of the principles, particularly of neuroprotective family-centered developmental care, because they're still very vulnerable when they graduate out. So we had everyone take that. So there really isn't a sense of cliquishness. It's definitely a matter of their own choice. If they want to focus their clinical time in the tiny baby program, if they don't want to, they at least know the principles. And then as the babies are in the unit, these developmental care principles apply to every baby anyway. So they don't have to focus so much on the delivery room aspect or the very first week aspect, but at least they know how some of the other basics.
Mm-hmm. And I think one of the things you did early on there, if I remember, it's been many years now, but is that you actually did similar to what St. Joe's, I think, and this is where I was thinking some similarity, you actually broke them into the core measures, the 7 core measures, and had people focus on the different interests as well from that. So I thought that was a nice way you engaged people beyond that first few weeks as well in your program.
Right. The other thing that we have challenges with is our Neonatology Fellows. And I wanted to ask you how you integrate, or is this, do you have an academic program? Do you have fellows in your program?
No, we do not. So
Okay.
we're a non-university based institution. So we have just our neonatology attendings, and we have nurse practitioners, but we don't at this point have residents or fellows. We are starting up a residency program, but our first group of residents won't be here for a couple of years.
I think that it's actually really nice to have this be a unit thing, that, you know, it takes a village, it takes the whole unit to care for these babies. And although there are some who focus primarily on that first few weeks, they're still very vulnerable for the rest of their NICU course. So that's why we chose to provide a portion of the education to everybody.
Absolutely, and that's a very good point.
So if you'd like me to unmute you, let me know. I can do that. There are others. I wanted to just say thank you to Dr. Phillips, who's going to be one of our speakers on Friday as part of our kickoff, as well as another session later. She has a vast array of topics that maybe some of you have heard her speak before, but I think you'll enjoy getting to know her through the course when she can attend as well. So thanks, Raylene, for being here. Let's see, I'm trying to look if there are other questions. There was a question about the NCC certification. And so that is, so NCC is a nonprofit organization based in Chicago that has currently many different subspecialty and specialty certification exams, and that's completely separate from this program. But it is something that many people are pursuing, either as part of the care of the low birth weight infant or even the neurocritical care infant. So there are two different subspecialty exams specific to NICU, so small baby or that. And some hospitals do pay for their staff to get certified, or they include the fees as part of the continuing education fund, and that staff may elect to use their funds in that way, either to take study courses, to buy books, or to actually sit the exam. And so those are two brand new exams from a few years ago. So I know Jane helped to work on the exam writing. I think Dr. Vargas is working on a textbook with them, and for all of that. Let's see. There was a question, I think somebody they missed one of your slides. They were wanting to see something. Let me see if I can go back. The overall algorithm of the small baby unit function. And
Okay.
then while you're finding that,
Okay.
how many nurses do you guys have at St. Joe's?
About 230.
About 230.
Is it this one or the one previous?
Let's see. I'm seeing who asked that question. Sorry, I just went away from the. So put in the chat if whichever one it was. It might have been this one, the overview one. Let's see. You can put questions here or in the chat. I'm just reading through all the different questions. There was another. This is a good one. So I know that Raylene just talked about that they have a kind of a small baby cohorted unit. So what's your plans at St. Joe's for how you'll mix these babies in, or how do you mix them in now? And will you isolate them in a certain part or pod? What will you do?
No, that's a great question. And I think a lot of that has to do just with how your unit is designed. So just to kind of give you a little background, our unit, we have 76 beds currently. They're all private rooms spread over 2 floors on our hospital. So the fact that it's all private rooms, we decided we weren't necessarily going to have to cohort them together in the same space. So for us, the ELBW program is more of a personnel. So it's more of who's taking care of the babies during that time. Again, specially trained, specially certified folks that want to be on the ELBW team, be the ones who are managing those babies in the first 21 days of age. So it's not a physical space within our unit.
That is always a question people ask. Let's see, Lou, let me see, where is your other question? People want to know if they can reach out to you. So that I'll leave that on you, how you would like to handle giving out your contact info.
Absolutely. Shoot, I thought usually I put my email on the last slide. I think I just forgot to do that today. but I'd be happy to. Do you want me to just email it to you, or?
Yeah, or you want to put it in the chat if somebody's
Oh,
on here, they can grab
yeah.
it, and then we'll be sure we can put it in your bio in the course for sure.
Perfect, perfect. So I will try to join the chat here, and I will put
Excellent.
my email in.
While you're doing that, I'll ask another question. Maybe you or Raylene want to talk to this. Is how about the financial impact of ELBW programs? You mentioned some of the other medical outcomes, but what about financial, short term, long term? Has anybody really looked at that yet?
Was that for me?
Oh, for you, yeah, for you, yeah, you or Raylene, whoever, whoever wants to chime in.
No, absolutely. And just one of the measures that we looked at, I think, shortened length of stay, that's huge for a hospital. It's a huge satisfier for like we don't work for our hospital, we have a contract with our hospital. So just 2 weeks ago we had our big annual meeting with hospital administration, and one of the things they love to look at is what is our average length of stay in the NICU. And one of the things that has been proven to benefit from having this sort of approach is reducing length of stay for these babies that are sometimes here for a very long time. Obviously our ELBWs are probably our longest tenants here in the NICU, so reducing their length of stay is huge. But then when you think about the economic impact of having less BPD, what each case of NEC costs, what each case of BPD costs, not only during the hospital stay, but after that baby goes home, how much resource utilization there is from early intervention programs to pulmonology visits to trachs if the BPD is bad enough. So I think the repercussions of being able to reduce several different morbidities in this high-risk group from a financial standpoint are enormous. And I think it exceeds just what you're saving during the hospital stay. Absolutely, I think it's something that carries on to when the baby goes home, and hopefully using less resources from the community.
That's all true. What we found is that we did have to show that data of the potential savings for length of stay. That's what they're particularly interested in, as long with the long-term ones, but they're not as financially interested in the long-term outcomes as they are in the shorter length of stay, of course. But we had to show them that because initially we all had to face the fact that there was going to be some costs up front. And the cost up front for us was we did have to renovate a part of a little section of our hospital in order to accommodate the cohorting of these babies. And secondly, there was the staff training that was mandatory for staff, so had to be paid for them. And that was a bit of a hurdle, but they bought it. And I think we believe it's going to pay off, and we have some data showing that so far.
Great. There was a question so far, Alfonso. So how did you get buy-in overall? So you did the invitation. Did you include other disciplines? How is that going? I mean, I don't know if you want to show the cake at this point, but.
Cake always helps. Cake and pizza. No, honestly, I think I think what created the biggest amount of buy-in or the biggest sense of need for this was actually looking at our data. So and when you're able to put that on a graph and show people this is how we're doing. On the good news, more of our ELBWs are surviving. The bad news is if you look at that beautiful curve of increased survival for ELBWs, we've got an equally not so beautiful curve of increasing rates of BPD over the last couple of years, increasing rates of ROP. And I think when visually people see that, I mean, we all want to do what's best for the baby. So by choice, this is what we've decided to do. So everybody who's attending this conference, our bedside nurses, our therapists, our doctors, we all want to do what's best for the baby. So for us to see that we're not doing well in certain things and that our outcomes are going in the wrong direction, that really makes you examine yourself and say, hey, we really need to do something about this. And it's not just eventually we'll get to it, it's an emergency, right? So there's a sense of urgency about our unit right now, looking at these numbers, looking at our data, and then feeling like there's something we need to do about this. So I think one of the biggest drivers is actually providing that sort of education to your staff, showing them because a lot of people walk around, they come to work every day, but you don't really know what's going on behind the scenes. You don't know what your morbidity looks like. You don't know what your numbers look like. particularly compared to other hospitals. And I think it's really important for all of you to maybe take a step back and say, hey, you know what, I haven't really looked to see what my BPD rates are or my NEC rates are locally. So if you, whether you participate in VON or you're a member of another database, like we have a couple of databases that we participate in, for us, it's really important on a continuing basis to not only look at our numbers, but how do we compare to other hospitals our size? Because we want to do a better job, but also pay is tied into that. You know, how insurance companies are going to reimburse hospitals is going to be tied more and more to what your outcomes look like. So I think we need to drive ourselves to do better by the babies, to make sure our babies are surviving better, to reduce resource utilization, all these great things. But I think once your unit as a whole is exposed to those numbers and knows exactly where you stand, there has to come from within a drive to do things better and to get better at what we do.
Someone made the comment about hard to schedule all these people when you have these specialties. You know, I think, Jane, you mentioned a little bit about qualifications to be on the team. So I don't know if you want to address that, because I'm sure your whoever's doing your schedule has already had this conversation with you.
I wasn't clear on that question. I'm sorry. So
yeah. So when we have specialty, like the specialty group of nurses, how does that impact your staffing, being able to have good coverage, giving people still enough flexibility to have days off, and then what are the qualifications? Did you include in that email when you decided you were going to email everybody about joining this program?
So I'll answer the first thing. So as far as staffing goes, we had the small baby classes on the calendar in November of last year that are coming up in March of this year. So we really look 6 months out and get buy-in from our nurse manager and from the person that does the scheduling and from the administration. And if there's an agreement that that's a class that they're going to honor for us and pay people to come in for, then we go ahead and put it on the calendar. It's a lot of looking forward and giving people plenty of time to register. Nurses don't want to know that they have to come in 2 weeks before the schedule's out. So we try really hard to get it out early, start promoting it early. And we do offer it over several days and different sessions. So that's tricky. That's hard on your speakers. That's hard on the people that are giving the class, but we have that level of commitment. We're very fortunate here from our neonatologists and from our leadership that people are willing to do that. And it's well received, and we're very fortunate because when we do have those classes, we have a huge attendance. So it's reciprocal. You feel very valued for being a speaker, and the team members are there. So
what about bedside staffing? So how do you staff for the small baby care?
So yeah, so I think when we can kind of go back to like what with our cooling program. So once we had our core group of cooling nurses, how do we make sure that there's always a cooling nurse available? Like how do we?
Yeah.
So I think a lot of that has to do with like numbers of folks, like, so you have to look at your own unit, and you have to have people from night shift that are cooling nurses or ELBW nurses. You have to have people from day shift. You have to have nurse managers that are also specially trained or ELBW or cooling nurses. So that way you try to, because it is hard. You kind of, I always used to kind of sweat that we'd have a shift where we'd get a really sick cooling baby and the cooling nurses are on. So I think a lot of it has to do with assessing the size of your unit, assessing the size of your nursing pool, and then making sure you have adequate numbers from both night shift and day shift of nurses to ensure that on any given shift, you're going to have at least a few nurses that are on your cooling team, but it is a struggle. I think it is a struggle. It's something we had to put a lot of thought into. And I think we've done pretty good with the cooling team. Our ELBW team is in the process of being formed, so we haven't actually had to staff for an ELBW unit yet, but that's certainly going into the planning of it.
Yeah. So more to come on that, I guess. And then what about qualifications, Jane? Did you have any minimum time people had to be in the unit, or any of, they had to be a certain clinical level or anything like that?
I will answer that. And what I'll tell you is we're here at St. Joe's, we have our bedside nurses every shift. Then we have one charge nurse, and then we have a dedicated delivery nurse and a dedicated resource nurse that does not have an assignment. So all delivery nurses are cooling nurses, and all delivery nurses are PIC nurses, and all delivery nurses will be elbow nurses. So, and when the person that does the schedule for days and nights, always make sure that we have a delivery nurse on every shift. So then we are certain that we have somebody that can do one or the other. Now they'll probably have to pick up the assignment. We do have to scramble a little bit until, but then the day shift can let the night shift know and staff appropriately and give them 2 people. And we have lists at the desk of who's on each team. So I think that's the answer to that. Thank you for helping with that, Dr. Vargas. Did I answer that a little bit better?
Yeah.
Or okay. And then the next question was, yes, we have made folders for the elbow team. I don't think they can I hold it up?
Oh.
Yeah,
This.
and in the folder, yes. And in the folder, it specifies, there's Kathy's calendar in here for all the classes, but it also talks about come to the first meeting, learn about the team and what you'll be accountable for. And that's in this email. And I'm happy to share these documents, after the webinar.
Great, thank you.
Did people need to have a specific amount of time they've been here?
I think it's important to invite everyone. I think interns can bring a lot to the table. So I don't feel that we haven't really talked about that, but I don't think, I think if you're interested, we can teach you.
Yeah.
I really do. Yeah.
Yeah.
Passion, I think, sometimes goes a lot further than experience.
Yeah.
So I think we want passionate people. We want people that actually that want to learn, want to contribute. And again, I think when they join our group or they decide they want to be cooling or elbow nurses, it's more about the education we provide them moving forward. So it's not so much about what they have behind them. It's more about what we put in their path that they have to complete to become part of the team. And like our cooling nurses, we did ask all of them to become NCC certified for NeuroNICU with the NNIC development of that exam. For elbow team, we're asking our nurses to become NCC certified in small baby. So on top of all the other education and ongoing things that we provide for them, hands-on experience. But yeah, so it's more about bringing their passion and interest, and then making sure that they complete the steps that we have for them to stay on the team.
Yeah, absolutely. Raylene, did you want to add something to that?
Yes, we did. We have been requiring that nurses have been on the unit for, everyone gets the training, but in order to work in the unit, they have to have been on the unit for a year. We have an 84-bed NICU. And what we have found is that the nurses who are brand new nurses, they sometimes don't have the management skills yet or the eyes to see when things are going south. And so I think that your method will work very well, especially if they have the NCC training, as long as they have good support from a more experienced charge nurse.
Absolutely.
Or a resource nurse that is always available. And that's also something that we've had a little challenge with, is the resource nurse backup. So in our case, we kind of have to have the front line be a little bit more strong. But if you have that strong resource nurse, I think your rationale that passion trumps experience really does work if there's good backup.
Yeah. So just for the sake of time, I'm going to just transition for just a minute, because I know a few of you have asked the question, more about this course, and maybe you hadn't heard about it until today and you just came and you're interested. And so I want to just spend maybe 2 minutes, go through this and let you know that there is still time to register if you want to join us. It will be an ongoing course over the next few months. And so let me just quickly, talk about that. So as many of you know, in Synapse Care, we talk about the 4 pillars of NeuroNICU, neuro-nurturing care. So we have neuroassessment, neuromonitoring, neuroprotection, and neurodevelopment. And a lot of our past webinars and past courses all focus on different parts of this. But we really did want to look at this special population that Dr. Vargas has just beautifully highlighted to us, and then figure out how we could care for them differently. And in our philosophy, this is a quote that I show at our annual One conference that would actually probably had just wrapped up if COVID hadn't happened. And it's really this idea of being one person and being enough. And actually it's I guess not a coincidence that Raylene is actually here with us today, because she and I have shared this passion for a very long time and have, really some stories to tell. But we both have this belief that I am one, but I am only one, but I am one. I can't do everything, but I can do something. And when Raylene and I used to teach together, she used to tell that story of the starfish, where this little boy is throwing starfish back into the ocean, and someone says to him, "What, you can't save them all." And he says, I made a difference for that one. And I don't know if that continued to resonate in my head as we began to implement this idea of being enough, one person being enough in one moment, one baby with one family, one moment, you make a difference. And so I'll give her influential credit for maybe planting that seed in the back of my mind of how important it is that each of us own that personal practice. And so when we started in the summer of last year talking about creating a small baby program, Jane and I were on the phone, and she said, you know, it's kind of like taking care of these small babies is kind of like a Rubik's Cube. And she and I had this like aha moment of, oh my gosh, this is the way to think about this and to really bring into a really tangible way what is the complexity, and yet still in some way nuanced and puzzle that these little ones are. And so we've developed the curriculum for the course really on these kind of 6 sides of principle, and that knowing that they are all interrelated. And for us at Synapse, that they're also related back to the baby's brain as well, and the impact there. So kind of trying to stay in our wheelhouse of how everything impacts that outcome. And again, thank you, Dr. Vargas, for that presentation. It was so good. It just wrapped it all together. So this is a sample of some of our agenda. Like I said, we have Dr. Phillips speaking with us on Friday. We have many nurses. It's an interdisciplinary group. So we're going to be focusing on neuroprotection and respiratory system, like I said. We have some great bonus webinars that are, kind of more in our normal NeuroNICU world, thinking about, NIRS and the use of NIRS to guide care. Of course, nutrition, which we've talked about already, using brain monitoring, getting special, unique programs like Barbara Rourke, who I think is still on the call, who's going to share her program from her unit around milk drops. And we're going to talk about skin and infection. We're going to talk about pain, stress, trauma. So we're going to hit all of this. We have some bonus lectures. Dr. Lynn Lynham is going to teach us all about normothermia. Terry Inder out of Boston is going to talk about MRIs and the developing brain and the impact of infection and inflammation. Bobby Pineda and her work on the SENSE program, she's going to talk about how do we support the microenvironment. Kara Ann Waitsman going to be talking with us about how does that position affect everything. And as you can tell from the conversations, we are doing these big live sessions every other week, but also having Q&A, small breakout sessions in between, because we know that the collaboration needs to happen in between the sessions. And it's not enough to just come and to learn, but to implement this either for your own practice using our one methodology, but also thinking about how do we then make this bigger for the whole unit. So if you have not yet registered, there is a last chance code that will give you 10% off. The price went up on Monday. So if you need to register, you just go to our normal website, courses.synapsecare.com, and then use this code on checkout and we'll get you set up. And if you have a big group, let us know. We do offer discounts for big hospital groups. So just reach out and ask about that. We can invoice you, the hospital can pay, it's no biggie. So don't worry about that. But I wanted to make sure those of you who had questions and were here live, I wanted you to know that you could still take advantage of all of that. So with that, I will stop my share. But anyways, all right. So I think Dr. Vargas and Jane, people could talk to you guys all afternoon. Raylene, thank you for being here. I think you can feel the energy of this community and how much, how much fun we're going to have together over the next 3 months. But this is just the beginning of the journey, of course. And we are definitely open to more, continued sessions. I've added on, it feels like every week I'm like, oh, I'm just going to add a bonus session because that's a great topic or that's a great presentation. And so we just keep adding and adding to it. And if you're part of it, you're going to get it. And sometimes I do just make these bonus sessions available just live because I want as many people to learn, even if you're not in the course. I think that some of them just deserve a big audience as well. The recordings will always be available to those who are part of the course, but the live sessions, we always invite you to come. We know that, the full commitment of a course isn't possible for everyone, but definitely come and keep an eye out on the calendar for the bonus sessions that we make public. So if you're on our email list, which you probably are if you're here, we'll keep doing that. And feel free to share these with those. But Alfonso, thank you so much. Any final words from you or Jane?
Just thanking you, honestly,
Yes.
Kathy. Thank you for what you bring to tonight, just your unit, our unit, but all units that you impact by bringing these courses, by bringing all this education, and again, your passion. So we really appreciate you, and thanks for having me today.
Yeah, absolutely. Have a great day, everybody, and keep in touch if you have any questions.
Thank you.